Good evening, everyone. How are you all? I am Dr. Arshan Ahmed. I am going to be your main mentors for the first aid AMC clinical most of the sessions. So again, let me welcome all of you in our free review session tonight. Tonight, you are going to learn about how to start your preparation for AMC clinical. You're going to learn how first aid AMC is going to help you to achieve that dream. Sorry, I think someone's microphone is on, and it always happens. So we're going to just keep you muted for the moment, and you can always ask her questions in our chat box. So I always keep the chat box open beside me. So if any queries during the class, feel free to just write something on the chat box, and I will always answer you. So First Aid AMC Clinical is a very well-known providers for AMC clinical preparation. We mainly focus on international medical graduates, and I am also a ING. I have passed through exactly the same thing that you guys are doing now. So I know the step-by-step approach because I have done everything. Like I was in hospital, I have done GP. I know all the pathways you can ask for, except not the specialist pathway because I was a junior doctor when I came here. And now gradually I have gained experience in this system. And throughout this experience, I also started like like it's not just me, like me with other providers. We started this course almost 8 to 9 years ago. And throughout these eight years, let's say, we have evolved, just like how the AMC clinical also evolved. Because nowadays you know that AMC clinical is difficult. They are making it more and more difficult so that like the right person can filter through that exam. And the passing rate always, like every year when we see the passing rate just drops and drops. But to make sure that our students doesn't fall behind, we have evolved ourselves in a way so that we fulfill those criteria AMC clinical examiners wants. And we exactly know that what really they look for. We know what are the main things why you are going to fail your exam. And we're going to show you each and every step how to avoid those situations and how to pass your exam in the first attempt. Now, many of you are our AMC MCQ students, and you know that we don't advertise about the course a lot. We like most of you are here because you have learned about first aid from your friends, maybe from your colleagues, maybe you're working in a hospital and someone else passed from our course, and that's how you are here. So when a course doesn't need that much of an advertisement, when you learn from others, I want you to understand that why it is highly recommended, why a lot of candidates come and join us. And throughout these trial sessions, you will learn about us. You will learn how we take classes. And we offer these 2 weeks free sessions for you. And in the 2 weeks free sessions, which is going to start from 15th of June, you will learn more about this course. I always say that don't join us just by hearing from someone else because you never know, maybe that person got help from us, maybe it is not the right course for you. So that's the reason why I'm going to always provide these 2 week sessions which will be completely free for you, and you can learn about us. You can learn how all of our mentors take their classes. And even after that, if you feel, yes, this is the right course for me, I'm learning from this person, yes, that means it is the right course for you. So it is really important that because AMC Clinical itself, just the fee of the exam is $4,000, which is really not cheap. So you shouldn't waste your time. You shouldn't waste your money on something that's not going to help you. So join our free sessions, learn about us. And if you think that this is the right stuff for you, then go and start the course with us. But I can assure you, when you join the course, when you learn about what are the materials and how we take our classes, you will love it. There was never it happened that our students did not like the class. And when our students go for the exam, the examiner get that vibe that yes, this candidate is not someone that I'm going to mess with. Examiner know that this candidate is well prepared. So we will make sure that you are that much prepared so that you get filtered in that exam. Out of that 36 student who will be with you in that same room, you will be one of them who is going to pass out of them. And that's what we are going to make sure. Now, tonight, we are going to start with AMC Clinical Introduction. We're going to show you what is the basic that you should know, how to start your preparation, and how we are going to help you to proceed further. Already, First Aid has got a lot of students who has enrolled into the course. And we are planning to give you the access a bit earlier. Like our course is going to start from 15th of June, but we are going to give you access to our student portal from the first week of June so that you can start your preparation. We're going to put some like essential videos. We're going to put some important stuffs in your portal already so that you can start your preparation rather than waiting for the course to begin. Now, First Aid AMC Clinical, throughout these years and years, we have evolved, we have updated ourselves as the AMC Clinical has changed. That was the first thing I told. How? If you have noticed our new website for First Aid, we have created a completely updated new student portal with a new website. Just because the old website was not fulfilling the criteria that we want our students to have. So now we have created a very, very good student portal where you're going to have a very smooth learning experience into that portal where everything will be very easily found. You can easily find out what are the important topics for your exam. You'll get all the class recordings. So it's going to be a massive update into our course. And most importantly, we are going to change our course notes. So the current note that our students are getting, that's going to be fully renewed to ensure that, yes, AMC Clinical giving us hard time, let's give them hard time back. So we're going to prepare you in a way so that the AMC Clinical exam is not going to be hard for our students. So there is a huge planning going on about the new updated course, which is you guys are going to be the first student of that updated course. And there is a huge amount of things that we are going to add. So I'm going to discuss that with you, usually at the end of the class tonight, and maybe in the middle of the class sometimes. So you will learn about the course in detail, but let's learn about AMC Clinical first, and then you can learn about us, okay? So AMC Clinical Exam is going to be one of the hardest exam that you are going to appear in your life. Now, by this, I don't mean to scare you. I want you to understand that any final exam, like if you are in any country, if you're going for your final exam, that exam is always difficult. That exam is not that easy to pass. Not everyone passes that exam. Only the person who is fully prepared, he or she can pass this exam without any trouble. So AMC Clinical is also the same thing. It is hard, but there is a reason it is hard because after this, you're going to be a doctor in Australia. And they don't want to take someone who is not fully prepared and they start working in Australia and kill a patient in here. So that's why AMC clinical exam is always going to be hard because they want a doctor who knows what he is doing. They want to get a doctor who can actually at least save a patient, not kill a patient in their own hand. So being a safe doctor is the one of the most important thing for this exam. Many of you are here who are a specialist. Maybe you are a specialist cardiologist, you are an orthopedic specialist, maybe you are a psychiatrist in your own country. But unfortunately, I've always seen that the specialists are the one who fail this exam much more than a candidate who is just an intern or maybe a postgraduate year 1 or 2. Why is the reason? Because as a specialist, you think that you can manage every patient by your own hand. You don't want to take help. You don't want to involve your senior registrar. You as a doctor there, as a junior medical officer, you want to like do each and everything. You want to put the cannula into the patient. You want to start the patient with IV fluid. You want to also take the patient to the catheter lab and put a stent into that patient. Now, always remember, you are a junior doctor in this exam, and you are going to be assessed as a junior doctor. You're not a specialist. There are a lot of tutors when they will explain their management, they will explain how to manage a particular condition. They will always say that I'm going to take you to the operation theater. I'm going to do this. I'm going to take you to the catheter lab, and I'm going to put a stent in your coronary artery. Now, as soon as you say that line, the examiner fail you immediately. So today I'm going to show you what are the traps. What are the traps which you are learning from maybe someone else. You are learning from some other providers, but actually they're giving you the wrong information and they are putting you in this grave disaster in the exam. So the number one reason why a candidate will fail in AMC clinical exam is that they are not a safe doctor. They want to do everything by themselves. So the first thing I want you to understand that when you go in, think that, well, I'm a specialist in my own country, but I'm a junior doctor here. So your thinking will be just as a junior doctor. So you'll take every help possible. So you'll not hesitate to take help from others because that doesn't make you any less doctor. When I was a junior doctor in a hospital in Australia, the first thing was that every case, every patient I'm going to see, I have to talk to the SMO, the senior medical officer. And if I'm going to order an investigation, I need to say that, yes, this is my patient. And I think this is what this patient might have. And I want to do this investigation, doctor. And then you can order it. Then the investigation came back, and you again go back to the SMO and say, Doctor, this is what we have found in the investigation. And I think that this patient has got an acute appendicitis. I think we should involve the surgical register. And then the SMO say, yes, call the register, ask him to come back. So see that like this is how the Australian health system will work. In a real life, you're not going to do things by yourself. Yes, you'll take a proper history, you'll do a physical examination on a patient, and after that, your diagnosis, differential diagnosis, your management, that has to go to a senior doctor. Especially like after a few months of working in the hospital, you will gain that experience that you can order investigation by yourself. And then you can come to a diagnosis, and then you can talk about the management with your senior doctor. So in AMC Clinical, when you manage a patient, the first thing is that, yes, you explain what the patient might have, and then the further management, the specific management will be discussed with your senior doctor and also with a specialist. Like if it is an acute MI patient, we are going to involve a cardiac register. If it is a fracture patient, I'm going to call the ortho register. So this is the first thing. And lot of course will actually, when they explain about the management, they will say all this. So say that I'm going to put you on this medication. I'm going to take you to the operation theater, and then we are going to go for a, like, let's say it's a case of appendicitis. I'm going to take you to the operation theater and I'm going to go for appendicectomy. Now, are you, as a junior doctor, will ever do an appendicectomy in Australia? No, never. As soon as you say that, examiner understand that you know nothing about Australian health system. So as a provider of Australian Medical Association, we are going to show you that how we work in Australia and what usually AMC clinical examiners look into you before they can pass you. Okay, so let's start. So you know that AMC clinical exam, now there is a new center which is in Melbourne. Now, if any of you already appeared the exam, you know how this looks like. You know the horror that you can feel when you go there. Now, when you actually finish our course, we will make sure that you get that much of a confidence that you don't feel that horror when you go into this Melbourne Center. So Melbourne Center is designed for face-to-face exam. So on that note, AMC clinical exam, there are two modes of clinical exam. Nowadays, it is mainly just face-to-face exam. Very rarely you might be able to get a online exam. This year, only few online sessions were there, and that was basically for doctors who are already working in Australia and who are actually working in a remote rural areas. So they got the priority to get into the online exam this year. So it's very unlikely an overseas doctor will get that priority. So my advice for you is not to wait for the online exam anymore. Think straight that most of you are going for face-to-face exam and start preparing for that. And our course is going to mainly focus on face-to-face exam. We will discuss a little bit about how the online exam is going to be, just if someone is there who needs that. But most of our session will focus on face-to-face. I passed my exam back in 2017. And this center was not there at that time. There was the NTC center at that time. So that center is a bit different than this one. So AMC has changed a lot, but the face-to-face exam, the mode, the how they actually take the exam, it is exactly the same. This is still happening inside the AMC Clinical Exam Center. So the inside is more or less same. And I want you to know that it is, I don't brag about myself, but I am proud to say that I passed my first examination, which is the clinical exam, 14 over 14 station. Now, many of you might say that, well, like, yes, you have passed it, but how come we can pass it? Or you might also ask that, well, it's not necessary to pass 14 station. As long as I pass the exam, I'm okay. And yes, that's what I would always say, that passing 14 stations is not your goal. But as a mentor who passed all the 14 stations in a face-to-face exam, I can assure you that I know each and every bits of AMC clinical exam, how it's going to be assessed, how it's going to be conducted. I know each and everything about it. And I'm going to show you throughout the course how to achieve that. Now, I don't say that you have to achieve 14 stations. As long as you achieve 9 stations, I'm okay. I'm happy, and you should be happy and proud about yourself if you can do that. And that's what you should be preparing for. Our goal is to pass the exam. Our goal is not to get a highest mark or highest passing stations. Okay, but if our aim is really high, if we want to pass 14 stations, then at least I might go down to 10 or 9 stations, right? But if I go for just 9 stations, then I might fall. I might fall to 5 or 6 stations. So your dream should be high up. And even if you can't achieve it, you'll not you'll not actually fall down that much. So your goal should be, yes, I want to pass all my stations in my exam. And yes, you will make mistakes. Most of you will have some mistake in the exam. So did I. My first case was breast examination. I was like horrified, my God, like that, because that was the exam. I didn't even do it on mannequin ever because I was overseas at that time. There was no one who actually even did any kind of like a preparation for us. In that time, like the first case was breast mannequin, and I was like, oh my God, I haven't even did that any time in my life. So that was a horrible experience. But the thing is that I knew each and everything about that exam. I practiced it on my home. I bought mannequin or doll, and I know how to do this. So I thought at that time that, well, if I fail this first station, that's fine. Doesn't matter because I'm going to pass all other 13 stations. So that is the thought you should have in your mind that if you come across to something that you are not comfortable or you don't know how to do it, that's okay because you have still lots of stations to pass the exam. So keeping your nerve is the most important thing. Okay. Now, AMC clinical examination, as part of that face-to-face exam, there are 16 stations. Out of these 16 stations, you get 14 stations which are scored and 2 stations are pilot stations, which means these are non-scored. Just like your AMC MCQ, you don't know which one is pilot and which one is scored, which means all the cases are equally important for you. Good news is that AMC has reduced their passing score because just few years ago it was 10 out of 14 to pass. Nowadays, if you just pass 9 out of 14, you can pass your exam. But I remember when this first came, everyone was so happy that yes, this is the time we are going to crack this exam. As soon as this happened, the exam got super hard. They have evolved in a way that nowadays, like it is so much change when a candidate go into the exam hall that yes, like a lot of us do a lot of question solve, we do recalls and all, but when they go into the exam hall, the case looks familiar, but it's just completely different. So this is how the AMC clinical has evolved throughout these years and years. And nowadays, this year, even the end of last year, I have seen that the exam scenarios, the exam mode, everything has changed in a very difficult way. So that's why I took that hard road that yes, now we need to also change our way of conducting this course because the clinical exam has got difficult. So that's the reason you will notice, if any of you did our course before, you will notice that there has been a huge amount of changes to make sure that we can make our candidates pass this exam without any difficulty. So out of 9 stations, so out of 16 stations, if you pass, you have 14 scored station, and out of 14 scored, if you pass 9, you pass the exam. Now, just to give you an idea, this is how it will look like. So let me give you a clear picture of what's going to happen. So let's say someone passed AMC MCQ. You don't need to pass clinical exam to go for clinical. So sorry, you don't need to have English test done to go for your clinical exam. So you have prepared your clinical exam preparation. And this is very important that when you think that you want to appear the exam, you might not be able to get into the exam because getting into the clinical exam is also very difficult. Because in a month, clinical exam is conducted 6 to 7 days. So you get only 6 to 7 days in a month. And each day has 36 students in it. Now, there are hundreds and hundreds of students who want to appear the exam in those months. So what happens that AMC Clinical, if you go to amc.org.au, you will see that in their website, they have this specific date and time that when the exam dates will be open. So if I show you that, because many of you even don't know that, and that's very sad that you don't know it, because the problem happens that many of you can't even get into the exam just because of that. So this is the amc.org.au, and I want you to see all the things from here because in here you will be able to learn everything about your exam. So if you go to the clinical exam, they talk a lot of things in here, but I want you to see that how to schedule an examination. So you will see that when you come here, that ideally they open the exam date usually 3 months at a time. Okay, so we are also hoping that AMC Clinical will open another 2 months this year, which will be October and November, but we are not still sure. So far, we know that the exam is there for July to September. And if you open up this file, you'll see that they usually will give you everything that when the date will be announced, this is the date where you need to actually register for the exam. So someone like if you want to appear exam in September, you need to be very careful that when your that clinical exam registration will be opened. Because if you don't know, there are lots of our students, even sometimes, even if we discuss this, still they just miss a whole year just to appear the exam. The problem with this is that when you prepare with us, that time you are preparing everything which is updated. And next year, the new cases starts to come up. So you need to start your preparation again. More and more cases will come, more and more new cases you need to learn. So that's why I always want you to make sure that have a set date and time, like at least a month that I want to appear in October this year. And then keep an eye on this website that when that exam is going to be opened for enrollment. Because the day it opens, within a minute, every seat will be filled. So what happens that at 10 a.m. in the Australian Eastern Standard Time, at 10 a.m., you will be able to log into your candidate account. So I will ask that you should log in before 10 a.m. and then it will be open. That yes, at 10 a.m. that this one will be there. So I want to proceed with AMC assessment. Then choose clinical examination. And when you choose clinical examination, they will take you through the instruction that how to schedule your specific date and month. Now, let me tell you, it takes 1 to 2 minutes for those whole 3 months to finish. So be very careful that don't think that if you come at 11 a.m., you will be able to get your exam seat. You will not be, trust me. Okay? You can see here that they always put the date that July, August, September. These are the dates that they have got. Okay. So that's important thing. Now that you have scheduled your exam, you know that let's say you're going for an exam in August. So the AMC will send you back-to-back email that where is your exam is going to be. So make sure that if you are in overseas countries, it means that you need to come to Australia. You need to come to Melbourne to appear your face-to-face exam. For those of you who are already in Australia, you are lucky, so you don't need to worry about it. But for those of you who are overseas, you need to think ahead. You can't just apply for a visitor visa 1 month before your exam and you will be able to come here. They are making it very difficult. Even if you show that you need to come for the exam, still some of candidates, the visa gets rejected. So don't think it's something that it's confirmed that yes, if you show the exam schedule, you'll be able to come here. So talk to a migration agent at least 4 to 6 months before your exam and start the process so that you can get the visitor visa when needed. Okay, or even like at least minimum 3 months before you should start the process, because sometimes it takes more than 3 months for Australia to grant your visa. Okay, now let's say you got your visa, you came to Australia. You should think that if you just come 1 or 2 days before your exam, you'll not be able to cope up. It's a completely different country. Everything is different. You'll shake, because you'll shake in fear if you come for the first time in your life just 1 to 2 days before your exam. So my advice is to come at least 7 to 10 days before your exam. If you have friends, family, stay with them. If you don't, then make sure to come somewhere, make sure to stay somewhere which is a bit closer to your Melbourne center. The 1 or 2 days before your exam, visit the exam center and make sure to have a look. Make sure that if your exam is in the morning, just try to come in the morning on like maybe day before or 1 or 2 days before your exam, and find out how much time you need to come here, because Melbourne sometimes can get very congested. So it can take longer than what the Google map is showing you. So make sure that you know everything so that nothing can go wrong on your exam date. It's also important that you put on a professional dress when you go for your exam. For a boy, I will say like this is how you should put on. So a pant with a shirt. There is no need to wear any coats. Australians are very informal, so they don't like to put on tie. They don't like to put on suits or any coat. So forget about them. Just put on a pant and a shirt and just be like him. It's enough. You don't need to put on any apron. You don't need to bring anything else with you except you can bring your stethoscope. And that is the only thing that will be permitted in the exam room. Nothing else. You can't bring your watch because that is not permitted in the exam. Okay? Now, for female, any professional attire will be fine. Okay? Now, what happens when you go into the exam hall? You will be given somewhere like this where you can sit, and there will be locker where you can put your belongings. After that, they will take you in another room where they will give you a brief video of how this exam is going to be. They will also give you a card, and the card will have your details. So you can see that this is the card. So you will need to hang the card in your neck, and the card will have your name and candidate number. And also, they will give you that which station you're going to start first. So maybe her station is 1, and this is her first station. He is going to start from station 2. So like this. And he is starting from station 16. So they will give you that which station is going to be your first station. And then they will take you into this room. Now, you will feel really anxious at that time. And trust me, every one of us feel the same way. You are not the only one. But trust in yourself, trust in what you have learned, how much hard work you have done throughout these years. And if you pass this exam, your road to become a doctor in Australia is there. So give your best. Okay, so don't worry at all and just go with the flow. And that's how you should go, because you have done it. You have learned each and everything. You know a lot of cages. So just trust yourself. And once you start it, the first station is always the hardest station. Even if you know the case, you'll do a lot of mistake in your first station. And that is completely normal. Just go ahead. So how it's going to be? So as soon as all of the candidates stand like this, and who are these candidates? They are actually sitting on the resting station. There are 4 rest station as well. So after each 4 station, you get into a resting station. But so some candidates might need to just start with the rest station. And that is a bit bad luck because you're not getting one of the rest station, but that's fine. Don't worry, it can happen. So there will be a audio saying that your reading time has started. So you get a bell. So there are a couple of bells that you will hear in AMC clinical exam. The first bell means that your reading time has started. So each station, so you have 16 stations in the exam. In 16 stations, each station is of 10-minute duration. All right? And that's what the clinical exam structure says. So each examination has 16 stations and 4 rest stations. Stations are 10 minutes duration, 2 minutes reading time, and 8 minutes assessment time. So in the initial 2-minute time, see that this is the monitor. In this monitor, you'll be given a exam question. So there will be a question and there will be a task in here that what you are supposed to do. After 2 minutes, another bell, and that means you go into the room. So you open the door and the examiner will be standing over there, and you should greet the examiner that, hi examiner, or hello examiner. Examiner will say that, can I check your ID? So you will show your ID. Examiner checks that yes, you are in the right station. And then examiner will say that this is your station, or sometimes even they say that this is your patient, Sarah. Do you have any questions about this station, or do you understand your task? You say yes. And that means so you are actually, after this 2 minutes, when you go in, your 8 minute has already started, including this introduction with the examiner. So in real life, you don't get the full 8 minute. Most of the time, you will end up getting 7 minutes, 45 seconds. So when you practice the role play, then you should practice for 7 minutes, 30 seconds. So that in exam, you can actually finish a bit earlier than later. Okay, so you have got 2 minutes to read, and I will discuss each and everything, how to do this reading, how to brainstorm yourself today. And then 8 minutes inside. After that 8 minutes, there will be another bell. And it means this exam is done. As soon as you hear the bell, you are supposed to go out and you go to the next task. It's really important not to delay here, because a lot of examiners don't like that you're still talking after the bell, because someone else is losing their time when you're doing this. So please don't do it. And most of the examiners will not take anything into account, whatever you say after finishing your time. Now, there is one other thing which is called prompt. Sometimes examiner can give you a prompt that if a task is there, like history for 4 minutes, if it is written on the task, then sometimes what examiner is supposed to do, that after 4 minutes is finished, examiner will say, move to your next task. Or this is your prompt timer, move to your next task. So as soon as you hear that, it means that your 4 minutes is up and you are supposed to move to your next task. Okay, so these are the first thing you should know about AMC clinical exam preparation. There is no clock in the room to check the time. It is very difficult that how to know this timing. And this comes with a lot of role play with your study partners, and gradually you understand how to manage the time. So there is no way you can actually see any watch that how much time you have left. And that is how they make it difficult, right? Now, if you look over here, you might see one thing. See this one. So this this is how the inside might look like. So in the inside, you might see that now it's not always like this. So some might look like this, where you might need to sit here, an examiner will be standing on this area, and sometimes role player might sit on that area. Then there are other ways. So if you see on this room, you see that there is a couch here. So there in some rooms, there will be a couch where patient is lying, and you need to stand beside the patient, sometimes to do the examination or sometimes to ask questions. So there are different rooms and it looks different in every room. Now, moving on into assessment criteria, how each of these stations are assessed. Remember one thing, that stations assess clinical skills related to medicine, surgery, gynae and obstetrics, pediatrics, and mental health. So these are your main subjects for AMC clinical exam. And your assessment can be in both emergency department or in GP center. One of the very important thing to look at when you first look at the question is that where exactly you are. Are you in a GP setting or are you in the emergency department in a hospital? If it is a hospital, are you in a rural hospital or are you in a tertiary hospital? So these are the things we always look at when we start reading the question. We will dissect the questions today. We will show you each and everything that you need to learn. Our focus is on that today, not a lot of focus on the psychiatry. So each of the station focus on one of the four predominant assessment area. So history taking, examination, diagnostic formulation, management, or counseling. So what happens that they give you a task, and the task, every question will have a specific predominant area that you are going to be assessed. Although the task will be multiple, sometimes 3 to 4 tasks, but not all tasks are your predominant area. You will get, and you don't know that. You need to actually find it out from the look of the question. So those predominant assessment area can be, that means your main pass might depend on how you take your history. Your main pass might depend on how you come to the diagnosis or how you manage this patient or how you do the examination. So each station has this inherent quality that the examiner mainly look into. So before we go into that, let's have a look to the case distribution for the exam. So our case distribution are like this. Medicine and surgery, you get 5 to 6 questions. Pediatrics, 2 to 3 questions. Gynae ops, 2 to 3 questions. Psychiatry, 2 to 3 questions. And physical examination is usually 3 to 4 questions. For face-to-face exam, having a very good idea about physical exam is a vital thing to pass the exam. And from your course, we are going to start a face-to-face workshop, which will be held in Brisbane this year. And we are planning to also add it in Sydney and Melbourne. And anyone would be able to join that face-to-face workshop on our physical exam, where we are going to also add the necessary mannequins that you will be getting in your exam. So that's how we are going to plan for this course, to make sure you are fully prepared before you go for your exam. So these are the case distribution. From the case distribution, you can understand that medicine and surgery has the highest number of cases. So you'll see like a lot of discussions about that. But on the contrary, pediatrics also has got a lot of cases, but only few questions come from there. So sometimes that's the reason, that because there is a lot of questions in pediatrics, sometimes you will see that there is like you are putting a lot of time on pediatrics, but in exam, you're not getting a lot of questions. But unfortunately, nothing you can do about it. You have to learn these cases. There are very common questions come in exam from gynae and obstetrics. So there are set of questions. If you know those, then you are fine. Psychiatry is always difficult. It is one of the hardest one after physical exam. And in our course, usually we take 4 to 5 class on psychiatry to make sure that you are fully prepared on each and every cases that can possibly come in exam. Let's talk about the question structure and how different tasks can come in your exam. So first of all, when you look at a task, this is how a task looks like. First thing is that the task is divided into main two groups. One is it is a fully physical examination station, or it is a full station. So full station means you have to take history from the patient. You have to ask physical examination from examiner. You have to come to a diagnosis, do some investigation. So full station means you do everything. There are cages, which is these 3 to 4 cages that comes in exam, which is solely physical examination case, which means you need to do this case or you need to do a physical exam on a person, which is a simulated role player. And when you do the examination, you need to find out positive findings during your exam and give running commentary to the examiner. So we will show you that. So the first thing when you look at a task is it a physical examination case or is it a full case? This is how a full case will look like. Not all of these tasks. I'm giving you an idea how many tasks is possible for a case. So a 30-year-old female presents with sudden onset shortness of breath since last night. The possible task that exam can give you is history from the patient, physical examination from examiner, ask investigation from examiner, and explain that investigation to the examiner, give you a diagnosis and differential to the patient, and explain further management to the patient. So always in clinical exam, it is very specific from where you need to take history, from where you need to do the physical exam, who you need to ask investigation. So when you look at a question in that 2 minute time outside, you should always remember that from where you need to take the history, who you are supposed to talk about the management, who you are supposed to take the investigations, because it is different each case by case. Although you will be given the question in your exam room as well, but still it is a good idea to know your task in detail before you go into that room for your 8 minute station. So AMC clinical exam, especially the face-to-face exam, is well known for not giving a lot of management in the task. Whereas online examination is known to give you a lot of management. I don't know why, because they might think that face-to-face takes a bit more time, that's why. But it's very common that face-to-face exam will assess you less for the management, more for how you take the history, how you come to the diagnosis and differential. So most of the case will have 2 to 3 tasks. But on the contrary, clinical exam has more tasks. Like online clinical exam has more tasks, and most of them would include management. So your focus for face-to-face exam should not be mainly on management, because they know that in real life, you are not going to manage this kind of patient. You might do the initial management, but the definitive management is usually done by the specialist. So that's why face-to-face exam, if you see the exam questions, how the tasks are coming, you will always see that the task is mainly taking a history, then physical examination from examiner, and give your diagnosis and differential. That's usually the pattern of the task. And yes, sometimes we also see management. So we will discuss management in the course in detail, but we want you to focus mainly on history, diagnosis, and differential, and how to come to a proper diagnosis. That will be the main plan in our course. Because if you don't come to a right diagnosis, you are going to fail the case anyway. Whatever you do doesn't matter. If your diagnosis is wrong, that is that. Especially if the predominant area is diagnostic formulation, then you will fail that case. Now, let's see how a physical examination case will look like. A physical examination case looks like this. A middle-aged patient presents in the emergency department with sudden onset of spinning sensation and unsteady gait, also having disturbing sensation in the ear. Task is to perform relevant physical examination on the patient, and they also sometimes give you that how much time you will have to do this. That means after 7 minutes, they will give you a prompt that your 7 minutes is done, go to the next task. Discuss your diagnosis and differential with the examiner. This is how a physical examination station will look like. That means in here, the main focus or the main predominant area is how you do your physical examination on this patient. Whereas the full station will look like something like this. Not all these 5 tasks. Some tasks will be history and give diagnosis and differential. Some tasks will be history, physical examination from examiner, and ask for investigation. That's it. So they will not give you 5 tasks. They will give you 2 to 3 tasks usually in the exam. And that's also one of the other important things. A lot of students, because they always, when they do the role play, they do history, they do physical examination, then they give diagnosis, then they talk about management. So what happens in the exam, because they have always prepared in this way, in exam, they don't actually see how, like what kind of task they have got. They do everything. They think that if they do more, the examiner will be more satisfied and they're going to pass. So remember one thing, that you don't get extra point if you say more, although you get negative markings if you say more than what is asked. That means it shows that you are not actually you're not actually punctual, or you're not actually like having a proper look at your task. You don't know what the tasks are. And that is also like a very, very bad negative assessment for you in your exam. So you only do what the task asks you to do. So how we are going to manage our time then? So we know each station has 10 minutes, and outside we have 2 minutes to think about that case. And then inside we have 8 minutes to perform that case. So the idea is that 2 minutes outside is going to be your vital moment, whether you're going to pass this case or not. Trust me, that 2 minutes is a very, very important time. And use this wisely. Use this in a way that you know everything that you are going to do even before knowing that patient. Now, one of the most important things, please do not memorize recalls. Please do not think that I know this case. I know that there is a case in exam. A student comes from a dentist because the dentist says that the patient is getting multiple dental caries. I know that this case always comes under eating disorder, like bulimia nervosa. Please do not think like that in your exam. If you do that, you will fail your exam without any hesitation. We always say that knowing the exam cases is important. It gives you confidence. It gives you an understanding what is being assessed. But it should not be your preparation. Your preparation is how to come to a diagnosis based on the patient's complaint, based on all the differential diagnoses that person might have, and then whatever information you achieve by asking a proper history, your diagnosis should be based on that. And that's how most of the candidates are failing their exam, because they come to the diagnosis prematurely, as if they already know the case. And examiners know that. There is a new things like AMC Clinical Examiners has given some tips. And one of the first thing that they have written, that it looks like that examinees already know their cases. And I don't know, like, how come they come to the diagnosis, because they did not even ask this question, but they know the diagnosis. Now, that is really, really bad, because it means that you might have just, like, you have done some course, or you have been in some groups where you've done some recalls, and your knowledge is very much constricted into that particular recall. And you fail that exam without any problem. Because when I do the cases with you, I know if you are just coming from a recall. I know that you have a shallow knowledge on that particular case. And examiner is exactly the same. They have been doing this forever. They know each and everything about IMGs. They know everything about you, how you prepare everything. So please make sure that your recalls are just kind of think it as an assistant. It's going to assist you to understand the exam scenarios, but it's not your main preparation. In our course, you're going to learn both. You're going to learn the cases, which is important for exam. But in our course, from now onwards, when we do the role plays, we do in a way that we can give you any kind of case, whatever we feel that we want to change, so that it becomes exam oriented. We don't follow just recalls. We might give you questions similar to recalls, but it will end up becoming a completely different case. And that's how we are going to prepare you. Because in our course, the course is divided as theory-based sessions. So you get all the theory with me, and I divide all the cases as cluster by cluster. You will see how I do it in cardiology class. And then you get also role play sessions with our other two doctors who are currently working in hospital as a registrar, and some of them are like senior registrar. So you need to understand, and they are going to give you a real life scenario, and they are going to make sure that you do this brainstorm when you're doing the role play with them. And also when you do role play with me, I'm going to give you the exactly the same feeling as if you are actually in an exam room. So that's what we are mainly preparing you for from this course. Now, coming back to this, so in the 2 minute outside, what you are supposed to do? In the 2 minute outside, the first thing you will do, let's say you are looking at this question. The first thing you do is read the full question. 30-year-old female presents in the emergency department. Look at which one is important. You pick up the important things when you read. So it's a 30-year-old female come to the emergency, sudden onset of shortness of breath since last night. I have to take history from the patient. I have to give diagnosis and differential to the patient. Now, how many time it will take to do that? What do you think, guys? In the 2 minute outside, you can't write anything. In the 8 minute inside, there will be a pen and paper. You can write everything you want. So just to read this, how many time you will have? What do you think? What is the proper time that you can actually waste on this? 30 seconds. Just 30 seconds. Okay? Within this 30 seconds, you will read your question. And you will read the main things that, well, I know it is a 30-year-old female coming with acute shortness of breath. I'm in an emergency department. I have to take history from the patient and give diagnosis and differential to the patient. You just do that in your mind, just in 30 seconds. Then your mind gets set that, yes, this is what I'm thinking right now. So you focus on the key points, you know your task, and then after 30 seconds, you start your brainstorm that what am I going to do when I start this case? So I'm going to go in, I'm going to introduce myself, I'm going to reassure this patient, I'm going to make sure patient is vitally stable. And then I'm going to start asking about her shortness of breath, and I'm going to ask about all the differential diagnoses I can remember. Remember one thing, that for every case, except the physical examination case, every case, your main assessment is on differential diagnosis. as many as differential diagnoses you can remember in that 2 minute time, the higher chance is there that you're going to pass this station. So in the course, whenever we do a cluster, we try to bring all the differential diagnosis a particular history or particular complaint can have. And we divide it into like which one is more relevant and which one is less relevant. So your relevant differential diagnosis should come first always. So what will you say? That I've got a patient, female, shortness of breath, sudden onset. So I need to ask about the cardiovascular. So I want to rule out MI, angina, pericarditis, aortic stenosis, aortic dissection. I want to rule out respiratory system, pulmonary embolism, pleural effusion. I want to rule out pneumonia, okay, pneumothorax. Then because this is 30-year-old, she might have a panic attack. So I'm going to rule out any anxiety. I'll ask a little bit psychiatry. Yes, I'm going to make sure that if this patient it looks like she can have a pulmonary embolism. So I'm going to ask about all the pulmonary embolism risk factor. I'll make sure whether she is on OCP, whether she can be pregnant. See this one, like this is called brainstorming. So this brainstorm only comes when you actually are well prepared, when you know your differential diagnosis. Like you close your eyes and you can see the differential diagnosis in front of your eyes. That's how it should be. So please make sure that whenever you get this 8 minute, this 2 minute time outside, the brainstorming is the first thing that is important. Your brainstorm should focus on the differential diagnosis. Okay, so the differential diagnosis should come into your mind back to back. And then you start your station. So if you can remember differential, you will see that how much confidence you get when you go in back to back. You are just asking questions. You are not thinking in your head because you know what you want to ask. Okay, so please make sure that you have memorized as many differential as you can. So this is how we are managing our time. Now moving on, how to find out that how much time I am going to use for each task in a particular station. So you need to first know that how many tasks you have got. And based on that, you need to divide your task timing wisely. A candidate who passed the exam knows exactly how to divide their time in between the tasks. And when you read this question, what do you think that the predominant assessment is here? What do you think, guys? Just tell me that if you are an examiner, what will be the main thing you will be looking for as the predominant assessment area? Just to make it a bit easier for you so that you understand that how they mark the exam. So just this particular station, the mark will be like this. Approach to the patient, that gets a mark. Then history will get a mark, and all of this mark will be from 0 to 7. Then diagnosis and differential will get another mark. And then examiner give a global score based on your whole performance. Remember, global score is not an average of all these three scores. Global score depends on a lot of things. We will come into that. Now, in this particular case, the likely chance either it is the history taking or coming to the diagnosis is the main thing. In this case, because if you don't take a proper history, you can't come to a right diagnosis. So diagnostic formulation will be the predominant assessment in here because they are not asking you to make a management, they are not asking you to do investigation. So coming to the right diagnosis is what the predominant assessment area will be. So when you look at a question, you should also know that what is the main thing I'm getting assessed in this particular case, coming to the right diagnosis, because that's all this case about. Okay, so now it means that you have two tasks and you have 8 minutes. When you have two tasks, it is very easy to divide. So you get 6 minutes for history and 2 minutes for your diagnosis and differential. Okay, that's how you will divide your time. Now, come to this same task, same patients, but the task is three: history, physical examination from examiner, and give diagnosis and differential. The predominant assessment area still looks like coming to the right diagnosis. So diagnostic formulation. Now, how you are going to manage three tasks? Now you can't take 6 minutes for your history anymore. You need to short your history. So how you're going to do it? What do you think will be the right amount of time for each of these stations? The right amount of time is 4 minutes for your history, 1 to 2 minutes for physical examination from examiner, 2 minutes, or you can say 1 to 2 minutes for diagnosis and differential. And you can change a little bit. So that's how you should think, that I will not take more than 4 minute history. Now, how to know that your 4 minute is there? There is no way. It comes with lots of experience, lots of role play that will give you that idea that yes, I think my 4 minutes is done. There are cases where it will be written that history from the patient for 4 minutes. When it is written, the examiner usually gives you a prompt that move to the next task. When you get that prompt, it is ideal that you quickly finish your history. You don't need to finish just at that time. Finish what you have started, and then you move to the next task. Okay? Don't, like, let's say examiner said your 4 minutes is up, and then for another 1 minute, you continue to take the history. That is a very, very bad thing to do. You will fail that case. Okay? So please make sure to remember these things because this matters a lot in your exam. Either you pass or fail. Now coming to this task, the same case, but there are 4 tasks. Now there are cases, but very small amount, maybe like highest maximum 2 or 3 case will be like this, where you might get 4 tasks in the exam, but very rare. Especially for face-to-face, it is very rare to get 4 tasks. Maximum 3, and most of the time 2. So your task is history, physical examination from examiner, diagnosis and DD to the patient, explain further management to the patient. So this is a very tricky case. In such situation, you need to make sure to short your history, just relevant history. You just do a focused history. That means only things that is absolutely necessary. So you make sure that you finish it in 3 to 3.5 minutes, physical examination 1 to 1.5 minutes, diagnosis 1 minute, management at least you need to keep 2 minutes. Without 2 minutes, you can't finish a management. So see that like this is how it should happen. So based on the number of tasks, you need to know how to short your history and how to accommodate other tasks in that 8 minute time. A good candidate who will pass the exam will know exactly how to do this. And that will come with lots of role play, understanding how much you can say. And in our course, from this batch, there are a lot of role play is going to happen. Already the existing course is like that you get 6 classes on role play every month based on the recent exam related questions. But this year, from your course, we are going to start 1-to-1 role play. So you will be able to come to a Zoom session and just do 1-to-1 role play with our mentor. And we're also going to arrange an exam week whole day role play. So every month, when the exam week is near, in the first week, there will be 1 week where we're going to pick like 1 or 2 days where we are going to do all the cages role play from day to afternoon. And you will be just getting like we'll be doing role play back to back with us, and so that you get fully prepared, fully confident about your exam. And that is going to be really, really important for all of our candidates. The PE classes at the moment, so right now we are doing face to face. We take 1 month physical examination classes online. So we show you everything online. That's part of the course. And you will be also eligible to get into our face-to-face workshop. So that's going to be our first workshop. Most likely, we are going to start that in, in September. That's what we are planning, so that October, November students can learn everything before they go for the exam. Okay, or maybe it can be also middle of August. We haven't like kept the date yet, but that's going to happen. So physical examination, as part of the course, you are going to get a whole month physical examination class, and we are going to discuss each and every case which can possibly come in the exam. And that's really, really well oriented. And our physical examination is one of the best. And then also face to face, we will show you on a mannequin, on a person, that how to do it. Okay. Now, coming to how AMC mark a candidate. Now, this is going to blow your mind to know this, because without knowing how you are getting marked, how you're going to get assessed, it's very difficult for you to prepare for such a difficult exam. So, in each station, the examiner is required to determine a global rating for that station. The overall result for each station is based on some key steps. So each case usually will have 3 to 4 key steps. Now, what kind of key step or what is the key step? Nobody knows. Only examiner, they usually get a paper, like they usually have a tab, and on the tab, they can see what are the key steps for this particular case. And if you ask or if you do that particular step, they usually give a tick. And at the end, when they mark you, they see that if you have done most of the key steps. It's not a requirement that you have to get all the key steps done, but at least the maximum ones. Maybe if you miss one key step, that's not a problem. But if you miss all the key steps, you will fail the case. Even if you pass all the tasks, still you will fail because you did not do the key step. So each station will have particular key stations, and the key steps are basically like for a shortness of breath, like the case that we are doing. What is the most important key step? What do you think? Like acute shortness of breath in a 30-year-old female. What are the key steps can be in that particular case? What do you believe? Yes, very important, vitals. Whether my patient is vitally stable. Second, whether this patient had any previous deep vein thrombosis or pulmonary embolism, or a family history of pulmonary embolism, or does this patient has any other risk factor of having a PE, like a recent travel history? What else? Smoking, for that, it's not very important, not a key step. So vital, yes, it's a key step. Having a proper assessment of the risk factor of pulmonary embolism is important. It should be also important that whether this patient can be pregnant or whether the patient is on any contraceptive. Okay, so you will understand from the look of the question that what can be the key step in this particular case. And if you follow our course, if you follow what we are showing you, there is no way you will miss this key step, because the notes that we provide, the classes we are taking, it's going to cover all the key steps, whether you know it or not. Now, The second thing is the relevant assessment domain for each station. So each station has a particular domain, right? So history, diagnostic formulation, accuracy of the physical examination, management and counseling. So those domains also will be important for your passing and an assessment of the overall performance of the candidate in that station. So three things: key step, relevant domains, and the overall performance. These are the three things that they are going to mark you. Okay. Now that's what the AMC says, that the scenarios used in the assessed station, it will have a clinical stem about the scenario, which might include investigation, imaging, or charts, a series of tasks, commonly 3 to 4, a suggested timing for the main task. So sometimes they can give you that timing that, yes, do the history for 4 minutes. Each scenario has a single predominant assessment area. Now that's what we are talking about, right? That every scenario will have something which is most important. Like for a physical examination station, how you do the physical exam, that means accuracy of your examination, is the predominant assessment area. You will be mainly pass or failed based on that. For the case that we have just done, shortness of breath, history, and diagnosis differential. So diagnostic formulation, how you come to the diagnosis by asking proper history, ruling out all the differential, and then you give your reason that why I think this patient has got a PA. That's how you're going to be assessed. Someone who has got a cancer, your main assessment will be how you counsel this patient. So all these scenarios that you get, there will be a predominant area where your examiner will give more focus. Okay. During the reading time, the candidate evaluates the given information, which we talked about, and these are not that important. Marking in the structured clinical examination. So we already talked that marking usually contains three components: key step, domains, and the global score. Each station will have several key steps and domains that are relevant to that station. Let's have a look. What do they mean by key step? Typically, in each station, there will be between 2 to 5 key steps. And examiner will either tick that yes, like the examiner has observed you that you have asked or you have done this key step, or they will say, no, you haven't done it. Domains. There will be between 3 to 5 assessed domains in each station. The candidate performance on each separate domain is rated on a 7-point scale. Domains may include patient approach, history, choice and technique of examination, accuracy of physical exam, differential diagnosis, how you interpret investigation, management, and counseling. So based on your tasks, so tasks are your domains. So each task you are doing, these will be your domains. But out of those domains, there is a specific domain which is the most important. And then examiner gives you the global rating. Global rating is finally examiner makes a global rating of the candidate's overall ability on the station on a 7-point scale. Global rating takes into account the predominant assessment area and also all the aspect of the candidate performance as demonstrated in that station. Remember that. So sometimes we see that candidate has done really good, and let's say history candidate got 4, diagnosis differential 4, management 4, but their global score came as fail. Why? Now this is a very gray area. AMC doesn't want to say why they do that, but the idea is that it also depends on the overall performance. Let's say you have done everything, but still you did not fulfill the satisfaction of the examiner, because there is the examiner. It's a very subjective thing. So if examiner did not like what you have done, even all the tasks you have got pass mark, still globally you can fail that task. Okay, so that's one of the problems. So in here, they said how we start the examination. So we talked about it. First, audio notification will indicate that start of the 2-minute reading time. So these are already, you know, that there will be a third audio notification at 8 minutes, which will conclude the first station. These are fine. Now, let me show you one thing, which is how the AMC clinical, the specification they talked about. So this is exactly how a question might look like in your real exam. So you are working in a general practice. Your next patient is a 37-year-old woman who suddenly became short of breath at work yesterday. Your tasks are to take a relevant focus history to enable you to further evaluate this problem. You should take no more than 5 minutes for this task. Obtain relevant examination finding from examiner. Examiner will only give you the result of the examination that you specifically request. Remember, this is a task which is different from the physical examination task. In the physical examination station, you need to do the examination on a person, and you need to find out the findings from them. But this task is you ask the examiner specific findings that you want to look in this patient. Like for a shortness of breath patient, you want to know the vitals. You want to do a proper respiratory and cardiovascular exam. So those things, whatever you are going to ask, examiner will only give you that particular finding. If you don't ask something, you might miss that thing, which might even help you to come to the right diagnosis. We will show you how to do that later on. And then the third task is to explain the patient probable diagnosis and possible differential diagnosis, giving your reasons. So all the tasks, there is specifically, they will mention what to do. Okay? And you need to remember it so that you don't miss any particular things. This is how it looks like the tablet an examiner uses. Their tablet will be like this. This is a sample mark sheet that MC Clinical Examiner uses. So your name will be there and the topic in here. See that there are key steps in here. So did the candidate exhibit the following steps in the station? First, inquired about history of recent travel, requested oxygen saturation, considered the likely diagnosis of pulmonary embolism. So for this particular case, these are the 3 key steps the AMC examiners will look into. So let's say you have done this, you haven't done that, you have done this. Next, these are your assessment domains. So every station has an approach to the patient. So approach to the patient is vital. It means that if you don't actually have a proper way of approaching a patient, like a professional approach, a patient who is crying in front of you and you are not offering tissue water, that's the approach you get 0. A patient saying, I'm very worried, doc, I think I have got a heart attack. And in your full management, you did not reassure the patient that I'm going to take care of you. You are here with me. I'm going to do the right thing. I'm going to make sure that you get the proper management. You are in a safe hand. So if you don't do those things, then your approach to the patient will be marked as 0 or very low score. So every station has this kind of things. Also, how an examiner thinks your approach is and how the role player also thinks your approach is will give you marking here. After every station, examiner usually asks the role player that how do you like about this candidate? If that role player say, I don't like him or her, you will not pass that station. So please do not do anything which can actually show disrespect or if you do any misconduct, or if you get angry with the role player in the exam, there is no way you will pass that exam. The second was history. Third was choice and technique of examination. And four is diagnosis and differential. These are your domains. In each of the domain, examiner will give you a mark from 1 to 7. Let's say in the approach, you have got 1. In the history, you have got 6. In the examination, 5. Diagnosis differential, 5. Now, if you do an average, the average might come like more than 4, but you will not pass this exam because if your approach is not good. If your approach is not good, you don't pass the exam anyway. Even if you get 7 in all other tasks, you will fail that station. So approach is vital. How you do a proper approach is why our candidates usually pass the exam in their first attempt, because we make sure that your approach is straightforward, it is polite, gentle, and it is what examiner likes to see in a candidate. Now, out of this, the global rating depends on everything, depends on the key step, depends on this whole thing, and it's actually at the end the examiner's choice. So sometimes it is a difficult thing because they don't do average of these domains. They don't do average of key steps. At the end, based on what you have done, if you satisfy examiners, then you pass the exam. If you don't satisfy, you fail the exam. So your global score means you are passing the station if you get more than equal to 4. So 4, 5, 6, 7, if you get that, you pass the exam or pass that station. Did it make sense to you guys? So I'm going to show you some of the questions which is very important for exam. And I want you to tell me, what do you think that the main assessment area in these questions? 24-year-old university student presents to your GP clinic due to falling grades. He has been referred by the university counselor. You need to take history from the patient, give your diagnosis and differential. What do you think is the main assessment in here? Predominant assessment. No, it's the diagnostic formulation. How you come to your diagnosis, that's going to be your main assessment. Okay? Let's see this one. 30-year-old male presents to the GP clinic with headache for 3 months. He has been recently promoted at work. History, physical examination from examiner, diagnosis and differential. The same thing. How you come to your diagnosis. So most of the assessment is how you come to your diagnosis, and how you come to your diagnosis based on a proper history, proper differential diagnosis. Because without that, you can't actually come to a diagnosis. You will not be able to show how you ruled out your differential. So most of those history takings where your task is diagnosis and DD, it means that the diagnostic formulation is your predominant area, and basically how you take your history, how you do your examination, based on that you come to your diagnosis will be assessed in the exam. Let's see this one. Very common question, you must have seen this. 50-year-old male present to you with a chest pain started 30 minutes ago. ECG showing an acute MI. You are in a rural hospital. Nearest tertiary hospital is 4 hours away. You have no option of transfer this patient at the moment. That means they're saying you can't send this patient for a PCI. You have to do something in this rural hospital for this patient who has got a ST elevated MI. Your task is to take a brief history, explain the ECG to the examiner, explain further management with the patient. What do you think in this case is going to be the main assessment? Is it history? Is it the ECG? Is it the management? Management, guys. That's it. So that means that if you take a very brief history and a focused history for 3 minutes and you put more time in your management, you will have better chance to pass this station. Okay? So it is the smart way to know. It is the smart way to appear the exam, that knowing that what's the most important thing I'm going to get assessed. Because then you can divide your time wisely. Okay? We will talk about this in our cardiology class about the management, Dr. Sana. But let me go ahead and show you that what's really important. So a middle-aged patient presents in the AD with a sudden onset of spinning sensation and unsteady gait, with a disturbing sensation in the ear. Perform a relevant physical exam on the patient, give your diagnosis and DD. What is the main assessment in here? Definitely how you do your, no, that's where you're wrong. It's not the diagnosis. A 7 minute is only on physical exam. In physical exam, sometimes even if you are not able to come to the right diagnosis and differential, you can pass that case. I remember in my first case, which was the breast examination case, my I had only maybe 10 seconds to give my diagnosis at the end. And I gave just like few, like breast cancer, breast cyst, fibroadenoma. That's it. And even between that, there was a ring. On the way to like come out of that room, I said, yes, it is fibroadenoma. That case I passed. I was sure that no, this case I'm going to fail because I couldn't finish all the differential. But the reason I passed is that I did a very, very good physical examination. I put my most of the time there, but eventually I ran out of the time. And that is a first station. And examiners know that first station, everyone is scared. So they are a bit like they don't make it very hard for you. They know that first station is going to be difficult. So they are a little bit more softer in your first station. So the thing is that like if you get your main diagnostic, main assessment well done, the chance is that even if you can't do the like in physical exam, even if you don't have much time to do your diagnosis and DD, you did a great job with physical exam, you might still pass that station. But I still recommend that please make sure you have time to do the diagnosis and differential. Okay. All right. So that's how the exam is going to be and how I want you to start your preparation. Okay. So I hope you guys got a very good idea that what is the AMC clinical exam, how the task looks like, how many different ways the clinical exam question can look like. And now you have a proper idea about the exam, right? Any questions about the mode of exam? How long you need to prepare for this exam? I would say that at least keep 6 to 8 months. That is the way to do it. Online exam is from home, not from the center. Now, I'm not still sure, Dr. Saira, that if there will be a face-to-face workshop in Melbourne, but I know for sure that there will be one in Brisbane this year, but it all depends. Okay, but there is a chance that we might do it, but at the moment we don't have any further information on that. Brisbane, it will be in September or mid-August. That's when we're trying to do. Okay, now let's move on. So you might know that First Aid AMC has been approved as a learning provider as part of CPD Home, and we are also a CPD contributors under AMA. And that's what you can see in their logo. So we are very proud to achieve that. And we also want you to understand that like not everyone get that status. We have shown that yes, this is a course which can help students, which can even help junior doctors who are trying to, who are just starting working in Australia as a doctor. So the course is designed in that way so that it's not just for passing the AMC clinical exam. It's also for someone who just want to start working in a hospital. And we're going to show you all the recent guidelines when we talk about the management. Our main focus of management will be from John Murtagh, RACGP, and most importantly, therapeutic guidelines. So that's what we are going to focus to give you the updated management guideline. And also the diagnosis differential, mainly we'll be trying to bring from all the resources that we can, and we put together to make it as better as possible. Yes, you can add this in your CV. And yes, all the materials will be provided as a PDF, and also all the classes are recorded class. Okay. Now, let's start psychiatry if we can. So thanks for still waiting for psychiatry class. So tonight we are going to give you just a little bit idea that how psychiatry looks like. And this is one of the most important psychiatry class because you are going to learn about how to take a basic psychosocial history, how to conduct a proper mental status examination, and also it's going to prepare you for most of the psychiatric cases that comes in exam. As you might notice that psychiatry usually have 2 to 3 stations in exam. And one of them is always, like most of you will get a mental status examination, which is commonly known as MSc. So MSc presentation is most of you will get one case. So this class, you will remember when you get that case in your exam that yes, first class Dr. Arshan took, I remember he talked about this psychosocial history. And you will remember me. But don't remember me too much, remember what I'm talking today. So first of all, in a psychiatric history, the psychosocial history based on a step-by-step approach. And psychiatry is mainly based on how you take a proper history, because your history will help you to come to the diagnosis. Your history will help you to present the finding to the examiner. So a MSc case looks like something like this, that you've got a patient who comes to you with sudden onset of behavioral changes. And the family members or maybe university counselor is very concerned about this patient. And you need to take a psychosocial history from the patient and present the MSc finding to the examiner. So your history should focus on how to find that MSc presentations. So when we present mental status examination or MSc to the examiner, we follow this MSc format. And that is the thing that your history will be focused on. So first of all, let me just show you this mnemonic. What does it mean? So we follow this aseptic J3R. So we look at the appearance and behavior of the patient when we are talking to the patient. We look at how is the speech of the patient. Is it a normal? Is it very slow, monotonous? Is it very rapid, fast? Is it something that I can't even understand? What is the emotion? That means how is the mood of the patient? We look for whether the patient has got any perceptual disturbance, which is hallucination. How is the thought form of the patient? Thought form is based on whether you understand the patients or not. Thought form has different types. We will discuss that later on. Thought content is whether this patient has got any delusions. How is the insight of the patient? How is the cognition? Is this patient oriented to time, place, and person? And how is the judgment of the patient? So, and also, lastly, we do 3R, which is risk, rapport, and reliability. So all of these things we will try to find out with our history first so that we can present this to the examiner. So let's start how to start a psychiatric history. Our psychiatry history will always start with a proper confidentiality. So the confidentiality, a lot of people, they're like a lot of tutors, a lot of providers, they usually start in a very conventional approach, which means that it's been always there. Even examiners are tired of listening to this one-line confidentiality statement. Like everyone say, let me assure you, whatever we are going to talk today is going to be between you and me unless it is harmful for you or others. Now, even I am tired of hearing this line. And I'm sure the examiners are pretty pissed off this line. So I want you to try something a bit different, something a bit different than others. So take a little bit of time for this confidentiality, and that is fine because you are building a rapport with the patient when you do this approach. So let's say our patient is looking very sad and even the patient is crying. So you will say, how you start. So if the patient's name is Sam. Hi, Sam. I'm Dr. Arshan. I'm one of the doctor in this clinic. It's very nice to meet you. So patient who is depressed, they might not even say hello back to you. They might just look down and don't get offended for that. Then you say, Sam, I can see that you are really sad. I'm so sorry that you are feeling this way. But Sam, I want you to know that I'm here to help. You can tell me whatever making you upset. I'll try my best to show you the right direction and manage your condition. Sam, I want to assure you that whatever we are going to discuss today, it is confidential between you and me, unless it is harmful for you or others. Now, you tell me which one is actually better. And in AMC clinical exam, the simulated role players, they are actually advised that if you are not confident or if you are not comfortable to talk about your issues with a doctor, don't talk. So first of all, if you don't give confidentiality statement, they are not going to talk to you, they are not going to open up with you, and that is permitted. So you need to always, this is the first thing, and that's a key step in every psychiatry history. So if you don't say that, you fail the exam immediately. And the role player might just say some bullshit and you will never be able to come to the diagnosis because they're not going to say anything important to you. They will just say like whatever they want, and that is permitted. So make sure that you give a proper confidentiality to this patient. Okay, then usually when you say that, patient will start looking at you. That means patient is ready to talk. So you will say, so Sam, would you please tell me what's going on? So always start with an open-ended question because they might give you some important information when you say that. So Sam, would you tell me what's going on? What's making you upset? So a patient at that time, they might say that, I'm so sad. For me, I just don't want to live anymore because I killed a patient and I don't deserve to live anymore. Now, patient has given you a vital information in here. And you can see that this patient is very sad. He wants to even kill himself. If your next question is, so Sam, what's your mood these days? How does it look like? Just like as an examiner, you'd say that, will you like this approach? No. So whenever a patient says something like very sad or they're worried, your response should be like this. Sam, I'm so sorry that you're feeling this way. I'm sure I can help you. So Sam, how long you were feeling this way? The first thing that we ask is the duration, because duration is important to even make a diagnosis. So Sam, how long you are feeling this way? And what exactly happened? So find out that why patient thinks that patient has killed someone. So find out exactly what's bothering this patient. That will give you a perspective about this case. And then you can quickly move on. So up till now, you have taken a bit of a time, maybe 30 seconds or 40 seconds just to start the case, and that is fine. Once you have done this part, you can pick up, you can just go on, and that will not look bad. But if you initially start by, Sam, I'm here, I want to let you know that whatever we discuss, it's confidential. So will you please tell me what's going on? Now, if now you want to pass this exam and you want to finish everything in time, but that is not going to help in the exam, because if you show that you are here just to pass the exam, not to treat this poor patient, you fail the exam. One of the criteria is that even if these patients are simulated, they are made up role players, still you need to think that these are real patients and you need to treat them as a real patient. So we ask that how long this is going on, Sam. So patient says it's been there for 2 months. I'm so sorry, Sam. Sam, how is your mood these days? So now you go on. Now you start a bit, you will pick up. You pick up your pace. You start asking more and more questions. So how is your mood these days? Any times that you feel that you are unusually high, to rule out any mania? How is your sleep and appetite? Anytime if you find something positive in the history, like patients say, I can't sleep, then you need to ask detailed question about it. So you need to ask that how long that is going on. Is it difficult to fall asleep, or do you get up earlier? Do you get early, or do you wake up early in the morning? Patients say no. So do you get nightmare and broken sleep at night? Yes. Now, each and every one of them has some particular diagnosis behind it. If patients say that I can't fall asleep, that means the patient is anxious. Maybe there is some kind of anxiety disorder. I get multiple broken sleep. I get nightmare. So that's the indication of post-traumatic stress disorder. I get up earlier in the morning and I can't get back to sleep. That's depression. So all of this will help you to understand the case a little bit more. After that, now sometimes based on our task, we decide, are we going to ask more questions about this presentation or are we going to move forward? If the task is taking a history and just present the MSc to the examiner, you should not bother about differential diagnosis that much in this case, because you will not be able to finish it in time. So your main focus will be asking all the relevant thing by which you can present the MSc. And that is fine. You will not be assessed for differential diagnosis in this case anyway. So, but there are cases where you need to take history and then you need to come to a diagnosis and differential. When that is the task, then based on the patient presentation, if now by this time you know that this patient most likely have got a depression. Based on the patient's initial presentation, we already know that what could be the problem. If it is a psychotic patient, they will have behavioral change. They will have they will just say like unusual things. If it is a mania patient, they will talk so fast, so pressured, you will not understand what they're talking about. So just by the way patient is talking, you will have a general idea that is it a case of depression? Is it a case of mania? Is it a case of schizophrenia or psychosis? And these are the main ones. Okay. Now, if the diagnosis and differential is a task, then you need to go in detail, which means you think it is a depression case. So you will need to ask all the depression related questions in here, which is M-Psych caps. Now, we will take another class on this where we will show you what are these questions all about. If it is a euphoric patient, or you think it might be a mania patient, then you will ask all the dig fast question related to mania. If it is not a diagnosis differential task, from mood, sleep, and appetite, you straight go to suicide. In psychiatry, if you ask me that what is the most important thing I should not miss, that is the suicide risk. Every psychiatric history will have a key step of confidentiality and suicidal risk. So please do not miss these 2 points. So the suicide risk, you will ask that, do you think your life is worth living? Do you have any thoughts of harming yourself or others? Usually one of these questions is enough. If patients say here that, I think my life is worth living, you don't bother, you just move on to the next question. If patients say, you from the history, you already know that this patient doesn't think the life is worth living. So in that case, you will not ask it anymore. You will say that, right now, do you have any thoughts of harming yourself or others? If patients say yes, then you say that, do you have any specific plan? Have you ever committed suicide, or have you ever attempted suicide before? Okay. So ask about any particular plan, ask about any previous attempts. After you have asked the suicide question, next question is hallucination and delusion. And that is mainly for psychotic patients. So you will ask that, Sam, I'm going to ask you some screening questions that may seem quite strange to you. But please understand that these are screening questions for everyone. Because if you don't say that and you ask about this hallucination delusion question, most of the time role player say, do you think I'm insane? Do you think I'm having some mental problem? Now you will be like, at that time, you will be so stressed when when they are saying that, you will forget everything at that time. So just to avoid that encounter, just say that first, that these are screening questions and I ask it to everyone. So the first question about hallucination is, do you see, feel, or hear things that others don't? So see means visual hallucination, feel means tactile hallucination, and hearing means auditory hallucination. Then we go to the delusion question. Delusion questions are vast questions. Based on your main presentation, you can already know that, well, if it is a depression case, then you don't need to ask all these delusion questions. So each station or each complaint will give you an idea that which delusion this patient might have. That one you should definitely ask, and then based on your time, you can add few more. But for a psychotic patient, like a schizophrenia patient, you need to ask all the possible delusion you can ask for. So the main delusions are these 5. So we remember by RCGGP. Delusion of reference, delusion of control, guilt, grandiosity, and then we have delusion of persecution, also known as paranoid delusion. There is another delusion we ask along with this persecution and paranoid, is the delusion of jealousy, because it's a very commonly asked thing in the exam. So these are the common delusion question we will be asking. So you will say, so how you're going to ask it? Do you think someone is trying to harm you or control your thought? Now, to make it easier or to make it a little bit more faster, you can make this 2 together. Like, do you think someone is trying to harm you or someone is controlling you? Then you can ask, do you think people are always talking about you? That is delusion of reference. So they will say that everyone in the street is commenting on me. The neighbors are always commenting on me, whatever I do. So commenting, talking, that's delusion of reference. Do you think you are guilty of something? That's delusion of guilt. Do you think you have some special power? That's grandiosity. Now, delusion of guilt is commonly found in depression. So in a depression case, you will not forget about it. Delusion of grandiosity is commonly found in mania. So in a mania case, you will not forget about this question. In a psychotic case, all of these are common. So paranoid, control, delusion of reference. Even add that, do you think that someone is trying to harm you or control you? Do you think someone is very jealous of you? So that's delusion of jealousy. Now, don't think that is the finish of the delusion. There are few other delusions. So we have thought insertion, thought withdrawal, and thought broadcasting. So we ask the patient, do you think someone is inserting or withdrawing thoughts from your mind? So in one question, two is done. Do you think your thoughts are being broadcasted in TV, newspaper, or radio? Now, you don't need to ask this to every case. Just keep this for schizophrenia case. For depression case, just ask few. Like you should definitely ask about these two questions and then just ask about the guilt in depression. And that's it. You don't need to ask anything else because very unlikely a depression patient will have thought insertion, thought withdrawal, or thought broadcasting. So based on the presentation, you can reduce the amount of delusion question. Then quickly ask about insight, judgment, cognition. So for insight, do you think you need some medical help? For judgment, let's assume, or you can say, let's think there is a fire in this room. What will you do? So if you don't say that, let's think if there is a fire in this room, sometimes these role players say that, oh, there is a fire in this room. We have to run. So just to like avoid this, just say that, let's think there is a fire in this room. What will you do? For cognition, we find out if the patient is oriented to time, place, and person. So for person, do you know where are you at the moment? For time, do you know what is the date today? And do you know who I am? That's person. So time, place, and person, that's cognition. After that, we finish quickly because up to this, we have got everything we need for MSc presentation. If you think that you have taken a lot of time to ask this history, you can quickly wrap up your history. Just ask like any other past medical history or mental condition, any family history of mental condition, and you just go ahead. But if you have a bit of a time, or if your task is not MSc presentation, rather diagnosis differential, then you need to ask few of these questions. So we need to ask about heads. We need to ask about some of the differential diagnosis, if that is there, SADMA, past medical history, organic history, and family history. So what does this heads mean? So heads, there is a lot of mnemonic for heads, but the main thing in the heads is home. We have employment, then activity, drugs, then we have stress, or we also say sexual history. Now, there are lots of other S people use, but I don't use those S. Although heads has those specific mnemonic, but I only use this. And that's for because I want to only access this. I don't want to access anything else. Even sexual history is not needed. I will finish here. So there are lots of other S, but I only want you to remember stress, and that's it. And sometimes support. So ask about home situation and work situation. Home and work is really important part of our life, and this affects our mental health. So we ask, how is your home situation? Is there any stress at your home? Do you work or study? Is there any stress at your work? Do you have enough support? That is the only question you will be asking in the heads. So home situation, is there any stress at home? Do you work or study? Any stress there? Do you have enough support? If your task is differential diagnosis, you are supposed to ask some differential diagnosis question here. And we will discuss that later on. For MSc case, you don't need this. SADMA, SADMA mainly is smoking and alcohol and any other recreational drugs. So do you smoke or drink alcohol? Any other recreational drugs? Because drug-induced psychosis is an exam case. Like patient comes to you with taking a lot of ice and ice-induced psychosis. There is also a handbook case on that. So that's important. Then finish with any other past medical history or any mental history and any family history of any mental health condition. If you have some time, rule out any organic cause. An organic cause, mainly we rule out hypothyroidism, head injury, and any kind of fever or flu-like symptoms. Because this can mimic a psychiatric condition. So any change in your weather preference, any recent head injury, any fever or flu-like illness. And it's only if you have time, it's not mandatory to ask it. So these last few things are mainly needed if the task is diagnosis and differential. For a MSc presentation, these are not really important. If you have time, then yes, ask HETS and SADMA because that gives a very good perspective about this patient. But if you don't have enough time, forget about all of this. Just finish with past medical history, family history, wrap up the case and go to the next task. Does it make sense for everyone? Okay, good. So let's just summarize what we have discussed because now after that we are going for MSc presentation. So we give confidentiality and then we start the psychosocial history with duration, mood, sleep and appetite, suicidal risk, hallucination, delusion. We ask about insight, cognition, judgment. And based on our time, we ask HEADS, SADMA, past medical history, organic history, family history. Once we have asked the history, we will tell the patient that thank you so much for everything you have shared. Please excuse me for a moment. I will go and talk to my examiner and I'll come back to you. So always end like that. Don't just finish and go to the examiner. And a lot of candidates do that. Okay. So your next task is to present the MSc to the examiner. So how we present it? We say, dear examiner, I would like to present the mental state examination of my patient, Sam, a 35-year-old patient found by his partner trying to hang himself in the garage. Let's say we're actually discussing something like a patient who is trying to kill himself by hanging, and it's a severe depression case. So we give a brief introduction and then we start with the aseptic J3R. So first, appearance and behavior. How does the patient looks like? So there are a few points we look into. So how is the dress? So he is dressed appropriate to the weather. Is he well groomed or unkempt? Is he cooperative or not? Is he maintaining an eye contact? Is there any abnormal body posture? So some patients who are anxious, you will see that they are frequently fidgeting, they are moving their hands, they look anxious. Mania patient will be restless, agitated. Whereas sometimes schizophrenia patient, you might see that they're looking in different areas of the room and trying to show you that he is hearing something unusual. So he's responding to some unseen stimuli. So everything they show you in a patient's appearance and behavior is really important. Okay, so first see how is the appearance and behavior. So is he dressed appropriate? Is he well groomed? Is he cooperative? Is he maintaining eye contact? And how is the body movement? Next thing is speech. How is the speech? Is it normal in rate, volume, and tone? So that's if your patient is having normal rate, volume, and tone, you just say that patient's speech is normal in rate, volume, and tone. A depression patient usually will be talking in a very slow and monotonous way and saying everything, taking time and very slow. Whereas mania patient will be rapid and pressure. They will be just talking and talking, and they will not even take breath in between. And depression patient will take a lot of pause in between. A full-blown psychotic patient, sometimes they will have disorganized speech that you can't even understand what they're saying. They're jumping from one topic to another, so it's very difficult to understand what they want to mean. So that's the speech we look into. That is it normal in rate, volume, tone? Is it slow monotonous? Is it rapid pressured? Then we look at the emotion. Now, emotion is divided into mood and affect. So we say that when we ask, how is your mood these days? If patients say that I feel very low or I feel very sad, so whatever patients say to you, that is the patient's mood. And you should write it in your paper. So this is one of the case where you should write aseptic J3R in your paper when you are taking the history. So that any positive finding you get, you just write in front very quickly. Otherwise, you will not be able to remember. The affect is what I observed. So as an examiner or as a doctor, what you observe in that patient is that affect. So affect is like if you think that, yes, this patient looks very sad and low, then yes, the affect I observed is congruent with his mood. There are some patients who are psychotic patient, and when you say, how is your mood? They say, okay, I'm fine. But the affect is not congruent because they are not fine. They are not okay. In that case, we mention that the affect I have observed is disturbed and is not congruent with his mood. Okay? The next thing is hallucination. So look for whether the patient has got any auditory, visual, or any tactile hallucination. Then there is two T. One is thought form and another is thought content. So thought form, most of the thought form is linear. So linear thought form means that if you understand everything patient is saying to you, that's a linear thought form. A patient who is manic, that means mania patient has a specific thought form known as flight of ideas. So flight of ideas is a thing where patients jump from one topic to another, but each topic has some kind of relationship with the next topic. Like I say that, oh, I want to see my mom. My mom adores me. So what I've done is that this is where mom and next topic is also mom. But I'm just moving from one topic to another. I want to see a movie with my mom. Okay, still there is a connection. Did you see that? Did you see the recent Snow White? Okay, did you see that recent Snow White movie? So that's the thing that patient will go from one topic to another, but each topic is different. So I want to see my mom. Then the next thing is mom adores me. Next thing is I want to see a movie. Next thing is, did you see the Snow White? Then he goes to another topic. So when patient jumps from one topic to another topic, that is what we call as flight of ideas. But each topic will have a little bit of relationship with each other. Whereas a patient who has complete schizophrenia, like full-blown schizophrenia, active schizophrenia, they will have loosening of association. But in exam, they usually don't give you this finding because in that way, you will not understand anything. But loosening of association means that patient will talk in a way that each of these sentence doesn't have any relationship with each other. Like we can say that, oh, I love psychiatry. That movie was really good. Oh, do you know, like, I need to go to the supermarket today. My friend is coming home to visit me. Now, what's happening in here that everything I'm saying doesn't really like mean anything. I'm just like saying shits. So when that's the case, when patients just say things that doesn't have any association with each other, that's loosening of association commonly found in a schizo patient. So that's the main finding we look for: linear, loosening of association, or flight of ideas. The next thing is thought content. In the thought content, mainly you talk about the delusion, but sometimes thought content also have overvalued ideas or obsessions. So overvalued ideas is eating disorder or body dysmorphic disorder patient, and OCD will have the obsessional thought. So these are all in the thought content that we can say. But mainly thought content is the delusion. And then lastly, we finish with cognition, insight, and judgment. So whether the patient has an intact cognition, insight, or judgment, that's what we are going to say. And lastly, you finish with 3R. So 3R comprises of risk, rapport, reliability. So at the end, we say that is the patient low risk or high risk based on whether the patient has active suicidal thought, active hallucination, delusion. So if a patient is having active suicidal thought, active hallucination, delusion, patient that doesn't have any social support, is homeless, all are high risk. Rapport, are you able to maintain a good rapport with the patient? And is the history reliable? Because a psychotic patient's history is not reliable. In that patient, you will say that I would like to take a collateral history from one of the family member. Okay, but many times, like if it is a mild depression patient, then their history is reliable. You don't need to take a collateral history in that case. So that's how you're going to explain each and everything in the MSc presentation. So you'll talk about all these aseptic J3R. You'll give a brief introduction. You'll talk about appearance, behavior, speech, emotion, perception, thought form, thought content. You'll talk about insight, cognition, judgment, and 3R. Now, it might look very overwhelming for you for tonight, but I will again explain this in our next class where we are going to do MSc cases. So we are going to do all the MSc case role play with you in our first class on those free 2-week session. Before we start that, I will again give it a go so that in case you have any trouble, you can always ask me at that class. Okay. Now, I want to do a role play for you to show you that how this actually works, because you need to know how to do a proper role play of a case and how to actually do this kind of case in a real life scenario. Okay, so you guys are ready? All right, just give me 1 minute. I'll just ask one of our doctor to act as a role player for this case.
Hi, Dr. Arshan.
Hi, Dr. Samira, how are you?
Very good. How are you, doctor?
I'm good, thank you. So let's do a role play, Dr. Samira, to show our students that how this role play actually works so that they can
Sure,
also start doing this. Okay.
sure, doctor.
What we'll do that I will be the doctor who will be asking questions,
Mm-hmm.
and you will be acting as a simulated role player.
Sure,
Okay.
sure.
All right. So let's start, guys. So I think one of you asked these questions that how to assess or how to do this kind of case. So let's see how we do this. So let me just take 1 minute, like 2 minutes to read this case and then think about this case. And after that, I'm going to start this case. And you can also learn that how it should be done. Dr. Samira, when I'm done, I will just say that I'm going to start, and then you can start it as well.
Sure, doctor.
Okay. All right, Dr. Samira, let's start the case. So
Yes,
you can give me the name of the patient, and then I will start.
David, doctor.
All right, let's start then. Hi, David. I'm Dr. Arshan. I'm one of the doctor in this emergency department. Very nice to meet you. How are you doing today?
Hi, doctor. I'm okay.
All right. So, David, I can say that the police is a bit concerned about you, and they were saying that you are roaming around the street. So, do you know like what's concerning them? What's going on?
Don't know, doctor. I live on the street. I was not harming anybody. I was
Okay.
just sitting there.
I know sometimes police can be sometimes they can be a little bit sometimes they can be a bit concerning for everyone. So David, I just want to assess you because the police seems to be very concerned about your condition because you are roaming around the street, and they want us to make sure that you are safe to go back to street. And I want you to know that everything that we are going to discuss here today is going to be confidential between you and me, unless it is harmful for you or others. And I can assure you that I'm going to help you if there is any trouble that you are having. Is that all right with you?
Okay, doctor.
So, so how are you doing these days, David? Are you all right? How is your mood?
My mood is okay, doctor. I, um, I don't know, but I think the world is going to an end.
So you think the world is
Because
going to
I,
end? So,
yeah,
okay.
I
Why do you
hear
think that?
this because I think I'm getting some information from the Holy Spirits. They keep talking about that, and they are telling me that I should do something to save the world.
So you can hear some voices. That's
Yeah,
right.
yeah, yeah, yeah,
How
yeah. I
how
will save
long
the
you are
world.
feeling that?
I will save the world. Yeah, yeah.
Yes, definitely. I'm sure, David, you are going to save the world. But can you tell me how long this is happening?
It's going on for past few months, doctor.
Okay. And how, do you see them or you just hear them?
I can't see them. I can just hear them.
Okay. All right. So and you say it's them. So how many are they?
I don't know. I can't see them, doctor. But it's always the same voice.
Same voice. Okay. All right. So and this is going on for a few months, you say.
Yeah.
All right. And do you think in like do the voices give you any particular command?
No,
No. And do you think the voices are going to harm you or they're controlling you?
no, doctor. I think they are trying to save the world. They're asking me to save the world.
Okay. Do they say how they're going to do that?
No,
No. All right. And any others, like, do you think that they know everything that you are thinking?
I think so, doctor. I think they know everything.
They know
What is
everything.
going in
Okay.
my mind, what is going to happen.
That seems to be very disturbing, David. No wonder why you feel like this. So anything like you think that like you have some superpowers?
I don't think so. I have any superpowers, doctor.
Okay. Do you think people are commenting on you or like everyone is talking about you?
I don't know about people, but these voices, they are always talking about me. They
Okay.
keep commenting about me.
Okay. All right. And what they comment?
I don't know, doctor. I can't hear it properly, but it is always about me.
Yeah, it should be really upsetting, David. So tell me about like, do you think like your thoughts are getting broadcasted to TV, newspaper, or radios?
No,
No. Do you think they're putting thoughts into you?
no.
Great. All right. And how about like, do you think you need any medical help?
Can you hear that? They are again talking about me. They are
Sorry.
telling me, yeah, they're telling, go and save the world, go and save the world.
Yes. Yes, David, that's right. All right. So tell me about like, do you think you need any medical help to get rid of these voices?
I don't think so, doctor. I don't need any medical help.
Okay. How about like if let's say there is a fire in this room, let's just assume, what will you do in that case?
I, is there fire in the room?
No, there is no fire, David. Just like an it's an assumption.
I will go out, doctor.
Brilliant. And do you know where are you at the moment?
Yeah, I'm in the hospital.
Okay. And do you know who I am?
You are the doctor here.
Brilliant. And do you know what is the date today?
25th, I think,
Brilliant.
25th of May.
Okay, that's really good. All right, David. So, and tell me that do you have anyone that you can talk to, like any family members that's around?
I live on the streets, doctor. I think my parents passed away long time ago.
Okay. And how do you manage yourself? Do you have any support, like financials and all?
Yeah, I'm getting some help from Centrelink.
Brilliant. And do you smoke, drink alcohol by any chance?
I don't smoke, but I do take alcohol sometimes.
Okay. And also any other medical condition, any past mental health history?
I think my mother told me that I have got something called schizophrenia. I was on the
Okay.
medication for a long time.
All right. And what
Yeah,
happened with
for the
that? Like,
past
did you?
yeah, for the past a few months, I stopped taking it because I was feeling all
Mhm.
right.
All right, I understand. All right, David, I'm going to like take care of that and see how we can manage this. And just for now, I'm thanking you for all the information that you have given. I'll just come back and I'll just talk to my examiner first. Okay?
Sure. Thank you, doctor.
All right. All right. So, dear examiner, I'm going to talk about a 47-year-old man, David, who was brought in by police in the emergency department, who had a venous ulcer on his leg, and he was roaming around the street. So, as part of his appearance, he was a bit disheveled, not that much well groomed, but he was dressed appropriate to the weather. He was maintaining eye contact with me, but he was looking like he was responding to some unseen stimuli. His speech was normal in tone, volume, and rate. There was no disorganized speech. There was no other abnormal, slow, monotonous speech. His emotion, his mood, he said it is okay, but it looks a bit disturbed to me. He had auditory hallucination, but no other visual or tactile hallucination. His thought form was linear. As part of thought content, he had delusion of reference and also thought withdrawal. His insight and judgment, his insight was not intact. He was oriented to time, place, and person. and his cognition was not disturbed as well. He is moderate to high risk because of active hallucination and delusion, and also homelessness. And I was able to maintain a good rapport with my patient. His history looks not reliable to me, so I would like to take a collateral history from the police. Thank you. All right, so that's it. So I just finished just in time. Thank you, Dr. Samira. All right, so that's how it's going to be, guys. Now, yes, if you have some time, ask about the ulcer question as well. Just say at the end, now it is not the must to do, but definitely if you have some time at the end, if you have time, just say that, David, I'm going to also check on your ulcer that you have got on your leg and make sure we take care of that. Okay, but it's not the mandatory. In the history, initially, you can also mention that when you're talking and giving the confidentiality, and at the end also you can mention that. Now, that's the thing, that you know in your head that you are running out of time. And at the end, patient told you about the schizophrenia history. Is it going to change your MSc presentation? No. And that's not going to fail you. If you don't take a lot of history about it, the diagnosis and differential is not a task here. So it's not going to fail you if you just quickly just say that I'm going to take care of it after we finish this. That's going to just be okay. Because I know from my head that I have already took like a lot of time. And if I don't go to the next task, I'll not be able to say everything at the end. So I just stopped there. I didn't bother to ask a lot of questions about that schizophrenia. And examiner has nothing to do about it because he can't fail me for that. He can fail me if I don't present the MSc. So that's a learning experience for you guys, that sometimes they purposefully will do these things. At the end, they will just say something which is really important to ask a lot of details. But you know in your head that if you ask 5 questions about schizophrenia at this moment, you will not be able to finish your MSc. And that comes with a lot of experience. That comes with a lot of role play. And you will know in your head that you will run out of time. Okay, so I always want you to make sure that do a lot of role play and understand that, so that you don't end up like getting into the trap that the role player is digging for you. So I hope you guys liked how we are taking the session. I hope this is giving you an idea that how to start your AMC clinical preparation. And the classes are going to be much more comprehensive than what we have taken, because if I had more time, I would discuss a little bit more about your MSc, which we will do later on in our first class of free 2-week session. We will do a little bit about the psychiatry MSc again to give you a warm up, and then we do a lot of role play on MSc. Normally, we used to do only one class on MSc role play, but from your course, this is going to be multiple role play classes on MSc itself. Okay. So if the task is diagnosis, you get diagnosis like major depression, abuse. Those are not diagnoses. Assault, abuse, violence are not diagnoses. Schizophrenia, anything serious and shameful, act like murder, etc. How would you say it? Like a strict examiner. It depends. So many times the task will be give diagnosis to the examiner, or task will be diagnosis to the patient. So that's totally fine. Although it looks a little bit odd to say that you are psychotic at the moment, but in exam, that's fine. You can say that you are having schizophrenia, and you can explain what is schizophrenia and all to the patient. So that is permitted. I don't recommend to do this course with AMC MCQ. Dr. Aman, please pass the MCQ first and then start our clinical course, because MCQ preparation is really difficult as well. You'll not be able to learn both together. How long is the course? So let's discuss quickly about how the course is going to be. Yes, so you'll get all the recordings in here. So if you go to our firstaidamc.com.au, so this is the website that you'll be looking for. So if you just type firstaidamc.com.au, this website will come up. And in the website, you'll go to the most popular courses. Then you'll see this extensive clinical course. Click on check info. And in here, you'll be able to see all our course details. So I'm going to just explain this to you. And again, we'll discuss more in our free sessions. So new course is starting from 15th June and it will end most likely 30th October or early November. Trial class today, 2 weeks free sessions will be from 15th June. And those 2 weeks are vital for you guys. Even if you don't want to join the course, please come and do this free class because it's going to help you a lot. And this free 2 weeks schedule will be added here in 2 to 3 days. And also it will be given in our First Aid AMC Clinical Facebook group. So these Facebook group are always updated. So you'll see all the updates coming up in here. Okay. After that, so you can also look at our previous trial classes in our YouTube. So this is our YouTube link. Now the course will include everything someone needs to pass this exam. I can assure you that our course has evolved. It's been updated a lot. As you can see, like if someone did our course or did our last trial class, you can see how we have changed, how we have added more and more comprehensive discussions. And that's what we are planning in your course as well. So the course will include full theory, and you will get an understanding about how we take our theory class in our trial classes, which is the 2 week session. We will do complete cardiology and few psychiatry and pediatric class with you as a free session. We do role plays on all the cases that we discuss. There will be recent 5 years sample questions discussion. So in the student portal, you will be able to see all the last 5 years questions solved that we have done with the video recordings of them. On the top of that, we do role play classes. Most of the week you will get, most of the week you get 2 role play class, but definitely one role play class on the recent question solves. And we discuss the cases that is frequently important for exam, and it gives you a exam oriented vibe so that you know how the questions can appear in your exam and how to do those cases in real life scenario. You will also get videos of last 3 years. So all the last 3 years role play classes that we have taken, where we have discussed most of the important cases that can appear in your exam. The recordings of those classes will be provided to you without any cost. Physical examination is really important. So the course students usually would get a full 1 month physical examination, which will be taken online. But there is also an opportunity for you to join our physical examination classes as a workshop. And that will be, as I said, we are thinking about late August to early September, but there will be some kind of like a subscription fee for that. We take online mini mock exams every 4 to 6 weeks. And we also take extensive classes on how to improve your communication skill and patient-oriented approach. All the classes, you will get recordings, and the recordings will stay there. It's not going to go away within a month or so. So everyone gets the recorded classes for minimum 10 months, and you can also increase your subscription of these recordings for 15 months if you want. So that you will not get in any course in Australia or anywhere in the world. But we make sure that we provide you that recordings because we know you are busy. You are a doctor, most of you, and you have a life. You can't just finish a class within a month. There are lots of you who might need to even go back and listen to this class just before your exam. And if I say that no, your recordings will be gone after 2 hours or after 2 days or after 1 month, it's not actually going to help you in the long run. On the top of that, all the classes the PDFs will be provided to you in our student portal. So anytime you want, you can come and just have a look at this. And you don't need to write notes in our class because we, we provide notes for you. We write everything from all the guidelines and you don't need to do this job. And you just listen what I say. You just try to understand how to improve yourself rather than like mainly writing your notes throughout the class, which is really not necessary. Okay, and it doesn't help because most of the time those notes you will not even look at the just night before your exam because it's very hard to write everything. There are 300 to 400 exam cases. And if you need to write notes for 300 case and also for some theory, I don't know that how this is going to work at the end. So that's why we make sure that everything that you really need, it's already there in our portal and you just go in and just read it. You don't need to take any other notes. I can assure you of that. The notes that we are going to provide you, it will be fully updated according to therapeutic guidelines, RSCGP, and John Murtagh. Extensive discussion. So this is a new things that we are adding in the course that we do job hunting and career pathway discussion as part of the course as a free sessions, but there will be an option of doing a one-to-one Zoom meetings with our mentors who are already working in Australia to give you some kind of like an idea that how to start job searching, how to write a CV and all. There will be a minimum subscription fee for that, but that will be very, very minimum because you are already doing our course. If you want to do this in somewhere, they ask you $1,000 or maybe like sometimes 700 to $1,000 just to give you a guideline about how to search for a job. So we're giving you everything in a very affordable price just because we also had the same struggle like you are doing now. You also get CPD hours. So there are lots of, because we are CPD providers as well. So if you if you buy that CPD providing plan, you will also get a certificate of 130 CPD point. And also we give you a course certificate, which you can also use as part of your CV. And that even like it's really not needed to get a CPD certificate. Even if you show our certificate, that is enough. Options of performing one-to-one role play. So this is also another extra thing we have added from your course that you will be able to do one-to-one role play with our mentors. And as I said that there will be a session every month just before your exam starts. The first week of the exam, we are going to start the whole day role play sessions, especially for those who are going for the exam on that month. All of our mentors are working in Australia for a long time. There are no mentors who is overseas or not working. Okay. There are course fee. There are 4 subscription plan. Please give it a read from here and that will make sense. If you want to enroll into the course, then contact us from here or it's the best way that if you click on register now in here, it will take you to the subscription plan. So you will need to write your email address. They will send a one-time password in your email to verify your email, and then you will be going through a step-by-step approach, and then you pay by your bank account, your credit card, and then you will get a confirmation about the course enrollment in your email. Very straightforward. We no longer provide invoices that used to cause a lot of problem with like candidates could not get answer from us. They were getting a bit upset about it. It was very difficult because we had to provide invoices to people or candidates, and it took a lot of time. So right now, there is no more invoice. You get registration from the website and you get all the things. You get a receipt in your email and everything will be just online based. Okay. So it's very straight, nice and easy, straightforward. It doesn't need any contact between you and us to send an invoice and waiting for days and weeks to get approval. Okay. So that's no longer there. So that's mostly all about our course. I wanted to show you one thing that when you choose a course, You need to always learn about the pros and cons of that particular course. And we are proud to say that from your course, you will get this difference between first aid and any other course that you can say to me, any other course. The difference between first aid and the other courses are we provide extensive notes for each topics and each cases. Some course you need to write notes in the class. You don't get any PDF file. Now, because you don't need to write anything, because everything is provided, you can save a huge amount of time, and because everything will be placed very smartly. It will not be haphazard. It will be all in one place, and you will just click and you can see everything there. There are courses where you need to watch their video recording multiple times to grab the lecture, because maybe first lecture you just wrote the notes, and the second time you again need to watch the video because now you need to listen to what that ex-tutor has said. Next, extended class recording. So you get extended class recording. Minimum is 10 months from when we start the course, which I said you don't get anywhere. Most of the course will give you restricted recordings with restricted hours of even finishing that video, which is really troubling for a lot of you. So most of the courses I have seen between 1 month to 5 months. That's it. Nothing more than that. And that is not actually helpful because after finishing the course, most of you will need to go through our recordings to get a proper idea. And that's what you will get in this course. Our main goal is to encourage you to prepare for the exam, whereas many courses, their main goal is to scare the students so that they can get enrolled in their course. This course is the most affordable course out of any courses which is a provider in Australia. But many other courses are quite expensive. They are expensive course. They don't have mentors who is working in Australia. And some have made it as a divided course fee. But at the end, if you want to really learn everything from that course, you will pay even double than what we are actually asking from you. So don't be fooled by multiple divided courses because sometimes that can be more expensive than any other course. We offer CPD certificate, but many don't offer CPD. We have this extra session on role plays, and you can do role play with our mentors if you come to live session. And there is no candidate who can ever say that they didn't get enough opportunity to do role play in our course. And many courses will not focus on role play. They will just try to teach you like whatever they can. We also not just focus on you passing the exam, we also focus on making sure that as soon as you pass your exam or even in between your preparation, you get your job. So there will be extensive discussion on job hunting. There are courses who doesn't have any contribution to job hunting or your next step to become a doctor in Australia. As I said, all our mentors are doctors in Australia, but many courses, their mentors just passed clinical exam and they are now a mentor. All notes will be updated following the recent guidelines. And that's our main focus in your course, that the notes will be remade, notes will be in a way so that you don't need to search anything from anywhere. And many other courses, their notes is just like change of name and just a copy paste of someone else. So when you actually join a course, I want you to see this difference is what you should look into. And I'm sure that the course that we provide, that's going to be the only thing that you really require for exam. And it is not just what I say. You will see that our students passing the exam every month. Even though clinical exam is getting harder, still our candidate managed to pass the exam in their first attempt. If you see any time in our course, in our Facebook, and if you go to the feedbacks, you will see that I can show you hundreds of feedback. So this is the best course for AMC clinical exam. So if you go here, you'll see that how many feedbacks. Now, all of them are candidates who pass the exam. So go through our portal or our Facebook even and see and look at all these candidates who pass their exam from this course. And there is a reason why. There is a reason why we do that. You can see hundreds of feedbacks in here. So I want you to see this and read this and get this kind of motivation which you need to start preparing for exam. Okay, and I can assure you that the course will be enough. All right. I think we talked a lot today. We are way behind our time. Normally our class is 2 hours, but I hope it did not bother you. I hope you learned what you wanted to learn, and I hope it gave you a purpose and a motivation to start your preparation. We will talk more in our free 2-week sessions. If you have any questions, any queries, you can always send message to me as in the messenger. And also you can send us an email or you can ask us in our next class. Any questions, guys? If you want, you can even unmute yourself. I'll just open up your unmute option. So if you any questions, feel free to ask it. And Dr. Saira, we'll talk about the portal again in our next class. I paid through the direct contact and got invoice, how to get in my account. Now, for someone who, if you have got an invoice and you got, then normally what we will do that we will give access to the portal in a week time. Just we will contact you at that time that make an account in our portal, and then you will be just make the account and we'll give you the access in that time. Right now, we haven't started giving access to anybody. It will be in a week time. Yes, it is. It is possible. Now, it is not possible if you don't have access to the recordings. So just be very careful that if you are going for any course, you need to have access to the recorded classes so that you can utilize you can balance your time with your work. Because otherwise, you will end up paying the fee, but you will not be able to finish the course. And even if you are able to finish the course, you might want to go back at some point and listen to that recording, but you will not be able to get it because they will just remove you from the access, and you need to pay again for that course. So if you have a proper course and guideline, then yes, it is easy to make a balance between work and study. And every one of us done it. You can also do it. It might take slightly a bit longer time, but it's totally fine. It is not a competition. No, Dr. Patma, we are not planning for any PE workshop at Perth at the moment. At the moment, our main would be Brisbane, and we will be focusing most likely for Sydney and Melbourne. If not, then definitely next year. But this year, Brisbane will be definitely there. But the other ones, it's based on how we proceed on the first workshop. But it will be that we will actually give you all the details. And if we start the Brisbane one, we will just need to see that like how the Brisbane ones goes, and then we will go from there. That's how we are planning at the moment. But again, if there's a lot of students from Sydney or Melbourne wants to do the workshop, then yes, we will try our best to do something like that. It will be in the weekends because I also work in here. So I can't actually take day off in the weekdays. So it will be in the weekends. We will talk about more as a CPD. So if you are already a member of RSCGP, you can add our classes. So all the classes that you are taking, you can add these classes as an educational activity in the portal and you will get the hours. There will be a free sessions for everyone about job hunting, and that will be in between the next 3 to 4 weeks. So we will also update you on the Facebook when that free session about job hunting will be. Definitely join that class. It will help you a lot. All right. Thanks, everyone. It's very nice to see all of you here. Hopefully, we'll catch up again in our next session on 15th of June. Thanks all. Have a good night.